the big thing for us is we're really talking about a disease called multiple myeloma. Okay, it's a disease of something called a plasma cell. Okay, so it's part of your immune system. Okay, but like any other cancer, it's part of your immune system that went haywire. So it's no longer behaving the way it's supposed to. Those of us in the room, there may be people who have pre-malignant conditions associated with myeloma or frank myeloma, newly diagnosed active disease. And it's really important for all of us to kind of consider, understand where we are in that spectrum, defining whether we do therapy, not do therapy. And I don't know who might in here have something called MGUS, or monoclonal gammopathy of undetermined significance, or smoldering myeloma, which is something that has to deal with disease that has a pretty good disease burden but still has no signs of active disease. And then the definition of myeloma, unfortunately, involves active disease. And those of you who have it know that there are certain end organ damage things we have to worry about and are very, very concerned about. And you've suffered for these things. And that's kind of a definitive answer for initiating treatment for you. And so what we want to think about is, what is it? Okay? How do we follow it? And then what are the kind of key concepts to initial therapy? Maybe the staging, prognosis. We also need to think a little bit about what do we do once we start relapsing, because, again, this is multiple myeloma. It's a disease that we have a lot of hope for because lots of new therapies, lots of very, very successful therapies. But we also remember this is still a disease that we can't make it go away forever for most people. In fact, most people we can't cure. So the big things for us, again, is multiple myeloma. What is it? Where do you live with it? And how are we living with it today? So one, we have to start out with, again, plasma cell disorder, a disease of cells that make antibodies. And that's critical for all of us because these antibodies are proteins that float around in our blood. And they allow us to measure and see what's going on as a biomarker of your disease status. Okay? And it's important for you guys to recognize these things because these are how we're going to follow your numbers and how you should follow your disease. Okay? These are what we call an M spike, one in your serum, one in your urine. If you come to see me a lot, I make you get 24-hour urines a lot because I like to see what's going on there and measure it that way. I apologize for that. I'm trying to break my habit and make it easier for you guys. No, I try. We follow your serum-free light chain, okay, your kappa and your lambda. We follow something called your IgA, your IgM, or your IgG, depending on your disease status or your disease type. And those are ways in which we can just track your disease over time. As these numbers are going up, that means our disease is getting worse. As these numbers go down, that means you are being successfully treated by somebody with therapy, okay? And that's how we want to think about it. So that's kind of a key concept for myeloma. Bad guys make these proteins. We can measure these proteins, okay? They go up, bad. They go down, good. That's about as simple as you can make it. I try to make it as complicated as possible by giving them different names and making me sound smart, but really all it is up and down. That's all you care about, okay? What we also think about is that myeloma is a disease that doesn't just sit there, okay? It doesn't just grow in your bone marrow. It causes problems all over the place, okay? It causes problems with your bone marrow function, okay? So the bone marrow is the space inside your bones where the manufacturing plant for all the white cells, infection-fighting cells, red cells, oxygen-carrying cells, platelets, clotting cells, they're all being made in the soft, gushy part inside your bones, and that's the bone marrow. One of those white cells is a myeloma cell or a plasma cell, and that's where it lives. And it can cause direct effects. It can make you have low bone marrow function, so you're anemic. Your red cells aren't very high. That's one of the key things we identify when it comes to diagnosing myeloma as active disease. But it also can cause renal failure. Okay? Renal means your kidneys. So the guys that filter all your urine, those guys can fall apart for a number of reasons because of myeloma. Okay? It also causes hypercalcemia, or high calcium levels. And that's because you have a lot of bone turnover. So your bones are full of calcium and they get released from time to time. And myeloma causes that. And they can cause significant issues. And any of these can be catastrophic. Okay? They can cause your demise. And then one of the ones that's kind of the most horrific for a lot of individuals, it also causes bone disease itself. So what the myeloma cells do is they mess up the normal balance in your bones about bone strengthening, bone strength. So as we're all sitting here in this room, your bones are being made and they're being destroyed. Okay? Certain cells tear them down and certain cells build them back up, so it keeps them strong. Now, as you get more mature, which is the same as saying older, that rate shows off a little bit already. But what myeloma cells do is they start turning off the bones that have the cells that start making bones. In the end, what happens is you end up having little areas of weakness in your bones. Okay, it can look like a moth-eaten appearance on X-rays. It can look like Swiss cheese, so to speak. Bottom line is it causes your bones to become fragile and they can fracture. So you can break the vertebral bodies in your back, the bones in your back, because there's lots of weight on them. You get compression fractures that causes lots of pain. If it gets really bad in your arms or your legs, it can actually cause spontaneous fractures. You can be picking up a bottle of soda and your arm will fracture. These are all things that we want to avoid. So this is how some people present still. And we call those end organ damage, we call those the CRAB criteria. So if you come see me, we talk about your myeloma numbers and we talk about your CRAB criteria. And that's our way of trying to figure out what's going on and making sure we're doing a good job controlling your disease. So your numbers are going down, okay? And we're protecting you from the end organ damage that happens, okay? Those are kind of critical concepts you have to think about when you have myeloma. There's a whole lot of things we think about in terms of staging, okay? In terms of prognosis. I don't know how important those things are for all of us today, but what it really lets us to do is kind of puts you in a category of a person that looks like this. We think you're going to do pretty well, intermediately well, and maybe not as fair as we want you to. Okay, we have 3 big risk categories. But what I always kind of emphasize with that is that I can give you a number, a stage. I can say you have a revised ISS, is what we call it, stage 1, 2, or 3. But what's really important for all of us to remember is that everybody in this room has their own multiple myeloma. You have your own path, okay? No matter what category I put you in, no matter what I tell you is your job is always to do better than I say. That's your first job. But our job together is to figure out how well you're going to do. And we're going to do that by getting you on the right path, which means the right therapy, the right sequence of therapies, okay? And obviously the right supportive care. And those are kind of the critical things we want to think about. So when it comes to getting myeloma, how do we follow you? Right? What are the things we want to talk about? So one, we always want to we draw lots of blood, right? You guys have learned that the hard way. Whenever you come see us, we're going to get lots and lots of blood from you. So if you're not anemic, we want to make you anemic, okay? Because I need a reason to treat you and give you chemotherapy. I mean, come on, if you're not anemic, I don't have to give it to you. But we just want to make sure we follow all those organs every time you come in and all of your disease, okay, the disease parameters, and that's how we monitor you over time. Now, what's important for us to think about is once we have something called active multiple myeloma, meaning you're having harm or about to have harm, we've done a very, I think, good/bad thing in the recent times is we've changed the diagnosis of myeloma a little bit. So I just told you myeloma is defined by having bad cells in your marrow, okay, by having abnormal proteins in your blood, and by having one of those 4 CRAB criteria or evidence of it. Recently, we've changed the guidelines a little bit where we can actually take people we think are going to progress really quickly because they have high burdens of disease or very, very subtle evidence of disease because we know certain things mean you're going to progress very quickly. And the numbers we throw around are if you have one of these 3 things, your chance of having active disease within 2 years is about 80%, 80. So what that tells us is we have the right or the ability to lump you into active disease and start therapy early before one of those bad things happen. Those 3 things are having a bone marrow biopsy that says you have lots and lots of plasma cells, more than 60%, okay? It also means that we get more, we've also enrolled or rolled into it more sensitive scans, okay, more sensitive tests. We used to get just x-rays to find those bone lesions. And just so you know, x-rays are great, but they're really not that great. They're a little bit of old technology. We need to have a lot of destruction of those bones before we see them. So you enrolled PET scans and MRIs. And so you have any lesions more than 1 on those tests, we can say you have active disease. And the one that I had the biggest trouble with is if you have a serum free light chain ratio, which is just 2 ways we can measure your proteins, greater than 100, we can also determine we call you active disease and start therapy to prevent you from having bad things happen in the future. I always tell patients we have to be very careful with those. They are new guidelines, they are new diagnostic criteria, but if you've been going around for 5 years or 10 years with any one of those things, that doesn't mean I'm going to start you on therapy, okay? Just because your history tells you that. And not that I'm going to give away any secrets, but I have this patient that I follow once in a while when he decides to show up and see me, who's been doing this for 15 or 20 years with a number of those categories. And so they're still not perfect, let's put it that way. But those are how we kind of define myeloma. And once you have that active disease, we have to think about how are we going to treat you, okay? How are we going to kill those bad guys, get them back under control, and then in turn make sure that we're going to keep them under control for long, long periods of time. And those treatments really are changing rapidly over time, okay? Most of us think about, we look at a patient across from us and we say, you know what, we have really good drugs that are highly effective with minimal toxicities. Never do I say no toxicities, and I'm sure people in this room would tell me pretty significant toxicities in some cases, okay? But these are generally drugs that we like to think, okay? I've never taken them, so I apologize, but we think we can give you pretty well, you can live, you can do the things you want to do for long periods of time that are highly effective, okay? And so say a patient comes into me, newly diagnosed myeloma, their kidneys aren't quite right, they're a little anemic, they have 30% plasma cells in their bone marrow, their M spike is 3.4 grams. We want to get them on therapy, they have active disease. And so I'll sit down across them and I'll say, what we got to think about is, we have a plan. This isn't just one time show, this is a marathon. We're going to be doing this for a long time. The rest of your life, we're going to be playing with this disease and trying to win this chess match. And so we start out with, we're going to give you 2 or 3 drug therapy, okay? We want to control that disease. With more drugs, we get more effectiveness, better chances of getting you into deeper responses, better chances of controlling your disease for longer periods of time. We also add a little bit of toxicity. Okay, I would tell you that today, most people I see, I want to push 3 drugs on there because, as I said, we want to control your disease the best we can. We want to drop those numbers as low as we can. But not everybody needs 3 drugs. Not everybody deserves 3 drugs, and not everybody can handle 3 drugs. Okay, they have to take into account the person across from us. If you are a young, healthy person, then 3 drugs should be just fine. If you're 89 years old, okay, or 89 years young, depending on how you want to look at it, maybe 3 drugs isn't the toxicity you need to put you across for. And that's how we have to think about our patients. We have to make sure that we can tailor our therapies for you. And we have enough drugs, and we have enough play in the way we can give our drugs to try to personalize our therapy for you. So back to this individual, they come in, we're going to say we're going to start them on 3 drugs, and a standard of care therapy for a patient today is using a drug called Velcade, using a drug called Revlimid, and a drug called dexamethasone. And those are the 3 drugs you're going to get. They all have their own set of side effects. That's 3 new pills or an injection I just gave you. Okay, Revlimid's a pill. Dexamethasone's a whole bunch of pills. I apologize. I don't know why they can't make the size we want, but they make you take lots of little pills. And then the Velcade is an injection you get under the skin. So if anybody tries to give it to the IV, tell them, I'd rather have it under the skin, please. And that's how we want to start out with giving you therapy. But that's not the only thing to do. That's 3 drugs. We have to protect you from those drugs. Okay, so always make sure you have the appropriate drugs on board to support you. Velcade increases your risk for something called shingles, and I don't think anybody wants shingles, so make sure you're on acyclovir or valcyclovir, okay? We'll make sure you're on aspirin to protect you from any clots in your legs and things like that from the Revlimid. And dexamethasone, most of you may or may not have experienced dexamethasone side effects, but anxiety, a little sleeplessness, some little bit of gastritis, those are all things you want to keep an eye out for so we can help you address those things. And then we're going to give you that for a number of cycles. That's going to take that number, we're going to drop it way down, hopefully to nothing, but we don't always get to nothing, but that's always our goal. And then if you're a young, fit person with myeloma, we want to consolidate that. We want to go to step 2. A young, healthy person with myeloma to me is anybody who's less than 76, 75 years old, so you can make your own judgment there. We do something called high-dose melphalan and autologous stem cell transplant. We all call it transplant, which is really an inappropriate term because the therapy is really that high-dose melphalan. Anybody who's done it knows that it's not the most fun thing you'll ever do, okay? It's not something you would volunteer for walking down the street, but it is definitely something that you want to consider when we talk about maximizing your chance to control disease for long periods of time. And that's where we are today, is still the main way of controlling and consolidating our initial therapy. And then after that, we're going to recover for a few months, make yourself feel good, and then we're going to put you on maintenance therapy. Good Lord, that's more therapy. Yep, we want to give you a little bit of a drug for a long period of time. Okay, we've learned over time that if you keep people on therapy, that we can keep your disease under control for much longer periods of time. And the most common one is Revlimid. You take it orally, 3 weeks out of 4 at a low dose, and you stay on there forever. Okay, well, not forever, but for long periods of time. We know that being on that essentially doubles the amount of time we have your disease under control, and allows you to survive longer periods of time. If we talk about everybody with myeloma, okay, and that's what studies have bared out. So it's important for us to kind of give you those options and to make sure the best of our ability we get you on that path. Is that path for everybody? Absolutely not. Okay? Some people can't do transplant. They're not fit enough. Fit. That means that either they're too old because we do much harm. The risk benefit isn't there. Some people have bad hearts, bad lungs. Other organs aren't working so well, so we can't do that. And so sometimes we have to, or some people say, you know what, I am the only person who makes money in my family. I have to live, I have to work, I have to do these things. I don't want to do it, or whatever reason else you don't want to do it. And we can drop that out and skip it, and we just go on to maintenance therapy without the high-dose therapy. But if you ask me the best way for someone who's healthy and can handle it, including therapy with high-dose melphalan and autologous stem cell transplant is the best way to go. I can tell you that it's not the best for everybody. We all have patients who've done very well with it, and I have patients who relapse early. Unfortunately, today, we don't know how to tell you this is going to work for you or not work for you. We're working on those things. That's what places like Moffitt does. We try to figure out better ways to help you predict what therapies to go on, okay? Not just to put you on the carte blanche, but today, we have to play an odds game, and the odds are, can I maximally affect your outcome? This is the way I want to do it. But again, if you're over 75, 76 or frail, that's really not an option. And I think the risk far outweighs the benefit in that case. So we want to control your disease, but still continuing on therapy is the number one goal. So that's the good time, okay? We do this, we control people for years in this setting for a lot of cases. The unfortunate reality is we all relapse at some point, okay? And that's really when I think the chess match really begins, because now we have to start thinking about what therapies are we going to do next. How do we control this disease? How do we make it a chronic disease? How do we keep you on this planet for as long as possible? And that involves kind of a sequence of therapies. Lots of success, we get you back under control, and we fail again, success and failure. And what's important for all of us in this room, and myeloma patients around the world, is a lot of research, a lot of volunteer time, a lot of clinical trials you guys have volunteered for, is we have an unprecedented jump in the kinds of therapy and the number of therapeutics we have for you to control a disease. Is it perfect? No. Are we curing you? Not enough, okay? We need to keep working towards that, but we're not there yet. But we've figured out ways and new therapeutics to keep you under control for longer periods of time. Again, generally well tolerated. And what's very nice is they all allow us to also personalize your therapy, okay? We can look at you and look at how you're relapsing. You're on maintenance therapy, you're coming up slowly. Well, we can watch a little longer. We have therapies we can fit just for that kind of relapse. You're relapsing very aggressively. We have other therapies we'd be more aggressive with that'll help us with those things. So all in all, the goal of all of this is to make sure that we're trying to address your disease, your needs as a person and a human, as a family member, a husband, a wife, a father, a brother, any of those things as best we can. And thankfully, because of all the drugs we have these days, again, none of them are perfect, okay, but allows us to better personalize our therapy for you and give you more options for therapy to control for long periods of time. And that's kind of how I would look at our disease. So what is it, okay? How do we diagnose an active disease state? How do we take care of someone with myeloma? And those aren't, I could speak for hours about all the drugs and drug combinations we have. In fact, Dr. Diaz told me I couldn't talk about that because I'd be here all night and you guys would fall asleep even faster. But we want to make sure we're there for you. And so I think, how long have I been talking? Am I doing all right?
No, you're doing just fine.
So the big thing is just to make sure we are here to work together, okay? Call us. People at Moffitt are there for you. We're here to see you, to help you through this disease the best we can, and work in collaboration with the folks in the community, who great physicians you have up here as well. You have a great group of people in this county, in this area, helping take care of you, and we're just a small part of it. So I'll kind of stop there, move on, and let you do as well.